Good afternoon, madam. Madam, can you hear me?
Yes, sir, I can hear you. Am I audible?
Yes, ma'am. You're audible. Madam, I have given you the privileges. Please try to share the presentation and your camera is off.
Okay, yeah. Shall I share it now? Namaste. Shall I share it now?
Yes, ma'am. Yes, ma'am. Another 5 minutes, so we'll start the session. Our
Okay.
CEO, Dr. A.M. Ramesh sir, will introduce, then we can start the session. Yes,
Sir,
ma'am.
the slides are visible?
Yes, ma'am. It's visible.
Okay.
Change the slides, ma'am, just for testing purposes. Fine, ma'am. Fine, ma'am. Okay. Thank you.
Namaste.
Namaste, sir.
Thanks for joining, madam.
Sir, we can start, sir. Yes.
Good afternoon. Welcome to Madam Dr. Preethi Reddy on behalf of KSTA and all the trainees who have joined on Cisco WebEx and YouTube platform. I welcome you, madam, for this series of talk. We'll be delivering the second talk, Women's Mental Health webinar series. I also welcome all the attendees who have joined on Cisco WebEx and YouTube platform in the Women's Mental Health series. We'll be having the second talk on menstrual related mental health issues by Dr. Preethi Reddy, who is working as assistant professor in the Department of Psychiatry, very renowned Nimhans Institute. Before beginning the talk, let me give an overview of the achievements, academic achievements of Madam Dr. Reddy. Dr. Preethi Reddy, Madam, as I told you, she is an assistant professor in the Department of Psychiatry. Hence, she has many contributions. Some of the important contributions to mental health are she has written book chapters, including those on the treatment of bipolar disorders and the neurobiology of depression. She has been instrumental in bringing out bipolar caregiver brochure booklet at NIMHAS, and she has been a part of organizing several national and international conferences, including the yearly bipolar CME at NIMHAS. Madam has several publications, national and international journals of repute, and she is also a recipient of many awards and honors. Some of them include WFSBP Young Investigator Award by the 14th World Congress of Biological Psychiatry, Vancouver, June 2019, and she is also a recipient of T.S. Srinivasan Bursary Award in the 11th International Congress of International Neuropsychiatric Association, February 2018. She had got travel grant by World Psychiatry Association under the Young Fellowship Program to attend WPA 17th World Congress of Psychiatry 2017 in Berlin. He has received Best Paper and Best Poster Presentation Awards at various national and international conferences. Her areas of special interest are mood disorders, neurobiology, biomarkers, endophenotype markers, women's mental health, bipolar disorder in the perinatal period, neurocognition and neuromodulation in psychiatric disorders, and neuropsychiatry. With this very brief background, I request Dr. Preethi Reddy, Madam, to take over and deliver the talk on menstrual related mental health issues. Now, over to you, Madam, for your presentation.
Thank you so much, sir, for that introduction. And I first want to thank Karnataka Science and Technology Academy for giving me this opportunity. First thing, and also a second thing, for choosing to have a webinar series on women's mental health. Mental health is important for everybody, all of us, whether it is a man or a woman. But there are.
Just a moment. I also welcome Dr. Bharat Srinivas, who is actually instrumental in helping me in organizing this webinar. Welcome to you, sir. Now over to you.
So as I was saying, the mental health is important for everyone, whether it's a man or a woman. But there are certain, and all of us know that biologically, because we're different, and there are certain challenges that women face through their life, because of which understanding and knowing about the mental health challenges that the women face during their life becomes important, because they need special attention and treatment accordingly. So the topic given to me today is about the menstrual related mental health issues going forward. So the presentation outline would be, so when we say menstrual related, it starts from menarche till menopause. So the presentation will focus briefly about the biology of menstrual cycle, and then about premenstrual syndrome and premenstrual dysphoric disorder, and then about how premenstrual dysphoric disorder is actually managed briefly. Then perimenopause and menopause, what are the changes that happen during these stages? What are the mental health challenges women face during the menopausal phase? And how these mental health issues are managed by psychiatrists and gynecologists. So I thought a brief introduction about menstrual cycle would be important, because there are as through my presentation, I'll be referring to certain medical terms. So it is important to understand them now so that you could get a better idea of my rest of the presentation. So the menstrual cycle is characterized by predictable and recurrent fluctuations in hormones, mainly the ovarian hormones like estrogen and progesterone. The cycle is separated into two distinct phases. First is called the follicular phase, which consists of the first part of the cycle lasting from menstruation to ovulation, typically lasting 14 days. And second is the luteal phase, which is the second half of the cycle following the ovulation and leading up to menstruation, and it consistently lasts up to last 14 days. So the days immediately prior to menstruation are often termed as a premenstrual phase. So this is a diagrammatic representation of the two phases that I spoke about, the follicular phase and the luteal phase, and then the period of menstruation and ovulation. And how the two hormones, the ovarian hormones, that is estrogen and progesterone, are fluctuating through the entire menstrual cycle of a woman. So during menstruation, estrogen and progesterone levels are relatively low, as we can see in the picture. As the cycle advances through the follicular phase, estrogen level spikes up, causing the pituitary gland to release a surge of follicular stimulating hormone and luteinizing hormone. This facilitates the maturing of the eggs within the ovaries. So when the most mature egg is released, the follicle transforms into a corpus luteum, which produces gradually increasing amounts of progesterone. A moderate amount of estrogen is also produced. Then, if the egg is not fertilized, then the progesterone and the estrogen levels will fall down steeply. The uterine lining breaks down, and the menstrual cycle resumes with menstruation, which typically lasts between 1 to 7 days for most women. Now, this is a brief thing about what the menstrual cycle is, what are the various phases, and what are the hormonal changes that happen in every woman. Now, what exactly is a premenstrual syndrome or premenstrual dysphoric disorder? So, PMS, what is commonly called as, and which all of you would have heard, is an entity characterized by the presence of psychiatric symptoms such as mood swings, depression, loss of confidence, anxiety, irritability, without any underlying psychiatric disorder, and it is also accompanied by some physical symptoms. So, this is an important point that there should not be any other underlying psychiatric disorder. For example, if a woman is already diagnosed with depression or anxiety, and during the premenstrual period, she is having a worsening of these symptoms, we could not make an individual diagnosis of premenstrual syndrome. Now, what is PMDD? Or dysphoric disorder is that a more severe form of PMS spectrum. It is characterized by cyclical recurrence of psychological manifestations, which includes irritability, nervousness, agitation, anger, insomnia, which is sleep disturbances, difficulty in concentrating, severe fatigue, depression, anxiety, and sometimes confusion as well. Now, as I mentioned, the symptoms of PMS can be divided into three forms: behavioral symptoms, psychological, and physical. So, behavioral symptoms are mainly fatigue, insomnia, dizziness, sexual dysfunction, sometimes overeating. Psychologically, there might be nervousness, anger, depressive mood changes, anxiety, difficulty in concentrating, forgetfulness. They become more emotionally sensitive, more agitated, feeling of restlessness. Physical symptoms can be headache, okay, mastodynia, mastalgia, that is pain in the breast. Then backache, abdominal pain, bloating. There could be some weight gain. There would be swollen ankles, hands, and feet. Some people have nausea, and general muscle and joint pains can also be present. Now, as clinicians, how do we diagnose, a woman with PMS or PMDD? Because many of us, women, would have faced either a few of these symptoms, a couple of these symptoms, or we might be facing it in every cycle or in some of the cycles. So DSM-5 is the diagnostic manual which we as psychiatrists use it, and this is the most recent edition of it. So the DSM-5 criteria is that one or more of the following must be present for the diagnosis. That is anger or irritability, sudden sadness, increased sensitivity, mood swings, tension and anxiety, or depressed mood or feeling hopeless and self-critical thoughts. So there should be one among these four. and to achieve a total of 5 symptoms. Because totally, to make a diagnosis of PMDD, we need total of 5 symptoms. One of them should be the above 4 which are there. And additional to that, there could be premenstrual irritability, concentration difficulties, appetite changes, like some food cravings, decreased interest in regular activities, easy fatigability, feeling very over situation. Again, like I mentioned, breast tenderness, bloating, weight gain, sleeping too much or sleeping too little. So these symptoms should occur in the luteal phase. So luteal phase is a phase which is just prior to the menstruation, like I showed previously. And it must be severe enough to deteriorate the daily functions, whether it is school or work or social life. And also the symptoms should disappear within a few days of the onset of menstruation. So when all this criteria is meeting, only then we do make a diagnosis of PMDD or PMS in a lady. But otherwise, if there are 1 or 2 symptoms which are happening, this could be these are very commonly seen in all women, which does not warrant a separate diagnosis per se and treatment per se. Now, prevalence. Prevalence, it's very important in medicine, because for us to understand how important or how common a particular disease is in a community. So looking at that, during the LPMC is a luteal phase of the menstrual cycle. During the LPMC, at least one physical or psychiatric symptom is there in 80% of the women. So this is what I was mentioning, that whole list that I showed. So all of us will be having at least one symptom, whether it's physical or psychological. So it's there in 80% of the women. When there are population-based studies that utilize very strict criteria for diagnosis PMDD, like the criteria which I showed, they reported that the prevalence is approximately around 2%. And there was another study which reviewed all the PMS studies done across the world. And so the difference here we have to note, in the second statement, we're talking about PMDD, which is a more severe disorder, which is only 2% of the population, which means to say 2 out of 100 people, 100 women might be diagnosed with PMDD. When we talk about PMS, which it is a little, lesser, milder, where all the criteria is not meeting. So when PMS studies were reviewed, it was seen that PMS prevalence is 47.8%. The lowest was 12%, which they saw in France and European countries. And the highest was around 98%, which was seen in Iran. Now, what are the risk factors? I've been telling that, all women, and we all know that we face these symptoms. But why is that? And the menstrual cycle that I showed, the picture, and the hormonal fluctuations which I showed, all of them happen in every woman. So why is it that some women are developing more severe symptoms or being diagnosed with PMS or PMDD? There could be certain risk factors. So one is very important risk factor, like in every other medical disorder or most disorders or most chronic disorders, is the role of genetic factors, the predisposition to PMS and PMDD. And studies have suggested an association of an estrogen receptor alpha gene, which might be associated. So women with this particular gene might be more prone for developing PMS and PMDD. Easier way of looking at is family history. If mother, grandmother, sister has PMS or PMDD, is more likely that particular family, the girl in that family might also have, might develop either a less severe or more severe version of it. Other risk factors would be smoking history or history of a traumatic life event, or there is an underlying anxiety and depressive disorder already being diagnosed. What is etiology? So in medicine, etiology means what are the causes for this particular disease or disorder. Now, let me tell you, for psychiatric disorders, most of them, there is no single individual cause that has been actually pinpointed and identified. But there are a lot of theories and hypotheses, and it's usually a combination of causes that leads to the manifestation of the psychiatric disorder. So some things are the best known hypothesis is the presumed role of the circulating gonadal steroids in the development of PMS syndrome. That is the hormones which I've already spoken about. There could be, some of the theories say that some women might have deficiencies in progesterone and progesterone metabolites, which some of them are actually anxiolytic. Anxiolytic means they actually reduce the anxiety. and there could be deficiency in the progesterone receptor function itself. So this could be one of the proposed mechanism for causing PMS or PMDD. There is current evidence which suggests that PMS is a disorder which is triggered by the changes in the gonadal steroids during the luteal phase in susceptible women. So again, it comes back to the genetic predisposition, okay, or the environmental predisposition. So there are some women who are susceptible to it. So what happens is susceptible to developing depression, susceptible to developing anxiety disorders. So during PMS, that is a premenstrual phase, the changes that happen in the gonadal steroids or the estrogen progesterone hormones make these susceptible women have these symptoms. There is evidence that cyclic variation in the circulating estrogen progesterone result in changes in the opioid, GABA, and the serotonergic systems. The opioid, GABA, and serotonergic systems are neurotransmitters which are there in our brain, which are very important mainly for the psychological symptoms, for the manifestation of psychological symptoms like depression, anxiety, and a whole lot of other psychiatric symptoms. So these are important neurotransmitter systems which are implicated in psychiatry. So it is seen, studies have shown that this cyclical variation in these hormones leads to changes in these neurotransmitter systems as well, and thus psychological symptoms are also noted. Several vitamins, dietary supplements have been studied as therapeutic agents for PMS, including vitamin E, B, calcium, zinc, magnesium. However, the evidence showing that any of these are more effective than placebo is very scarce. So, in medicine, placebo is an agent which is a neutral agent which does not have any action per se, which is used to study the effectiveness of medications. So in randomized control studies, usually when one particular medication and its efficacy is being studied, there is another arm which is a placebo, which is a neutral agent arm. So studies have shown that all these vitamins and dietary supplements were not more efficacious than any placebo agent that was given. Okay, so this was about the possible etiological causes of PMDD. So how can PMDD be managed? Now it's important. Now I know that the audience that I'm addressing today are not physicians, or they are not doctors, and they are not going to be treating people with PMDD. But I thought it is important to talk about the management of PMDD, is because if you recognize that maybe you are going through these symptoms, or you know of family members or friends who are going through these symptoms, you are aware that yes, there is a treatment strategy. There are some kind of medications or some other forms of therapy which are available, which a woman can actually go to a psychiatrist and take help from. So for that purpose, I thought it's important to mention the management as well. So now again, we can divide it into milder symptoms and moderate to severe symptoms. Talking about mild symptoms, so it's usually regular exercise and stress reduction techniques that are usually advised. Like, these stress reduction techniques could be having a regular, eating habit, regular sleep timings, maybe practicing some yoga or any other activity that you are interested in. Having a good social life where you are interacting with people, not very isolated or lonely. These kind of things could be regular stress reduction techniques. So there is one particular herb which is very well known in the market. It's called Vitex agnus castus, which is probably used extract for treatment of PMS symptoms. But I am putting this point because I wanted to highlight that sometimes when we Google things, Google throws in a lot of answers, and all of them might not be very pertinent, might not be relevant, might not actually be helpful. So one such herbal remedy is for PMS, which people use, which has been advertised, but it has very limited scientific evidence. What is the treatment for moderate to severe symptoms? Pharmacotherapy, that is what, when I say pharmacotherapy, it means medications, and behavioral treatments, that is psychotherapy or counseling or talk therapy, what we can call it, like cognitive behavior therapy can be given. There are two targets for the medications that are given. One is to enhance the central serotonergic delivery. Like I mentioned previously, that the cyclical changes in the hormones is also bringing up changes in certain neurotransmitter systems in the brain. One transmitter I mentioned is serotonergic transmitter. So, one target for medications is the serotonergic system. The second target, of course, will be the hormones itself, which are fluctuating or are changes are happening cyclically. So suppressing this hypothalamic pituitary ovarian axis to eliminate the physiological cyclical changes will be another target. And for that, the drugs which are usually used are combined oral contraceptives, which is estrogen, progesterone combined oral contraceptives. Now, talking about SSRI, that is the serotonergic treatment agents which are used for serotonergic treatment. There are 3 regimens which are usually used, and it depends on the duration and timing of the PMS and PMDD symptoms, and including whether a woman can actually predict that, maybe these many days before my menses, I get these symptoms, and whatever the patient prefers. So, the usual 3 protocols that are used by us, one is continuous use, which is very simple by the name. So there's continuous administration. It is recommended for women with mild symptoms occurring with long-term intervals, as the onset of symptoms cannot be predicted. For example, a woman starts having premenstrual symptoms maybe 10 days, even 10 days before her menstruation, and she cannot actually pinpoint, which day actually it starts. And also it is given in women with serious physical symptoms, and continuous dose regimens are more effective than intermittent regimens in these kind of women. So when you have serious physical symptoms or psychological symptoms which are interfering with your daily functioning, then it becomes important that a continuous use is required. Then there is a luteal phase protocol which we follow. This is recommended for women with predictable symptoms which last more than a week before the onset of menstruation. So like I said, before menstruation starts, that phase is called the luteal phase. So the treatment is usually commenced on the 14th day of the cycle, and usually it is stopped at the beginning of menstruation, because as per the criteria for diagnosis also, within 2 to 3 days of the menstruation starting, the symptoms will subside, but it can continue for a few more days in women who have persistent history of symptoms. So if some women say that no, I continue to have symptoms till the 5th day, then maybe we can continue from 14th day till the 5th day of menstruation. Then there is symptom onset treatment, also another protocol where intermittent therapy has shown to be effective, where the onset of symptoms effective from the onset of symptoms to the first few days of the menstruation. This is recommended for women with symptoms for less than a week, and they can easily pinpoint and recognize that, my cycle is 28 days. Every 28 days, my menstruation starts. And just like 4 or 5 days before I start menstruating, I tend to have these kind of symptoms. So if a woman is able to pinpoint that, then we give symptom onset treatment. Is that, this one day before the day where she says that, I'm going to have symptoms, she starts treatment. And when she starts menstruating, after a couple of days, we stop it. Again, I'm emphasizing on all this is because, I want to drive in the message that if there are women among you or whom you know who are having these kind of PMDD or PMS symptoms, they need not have this worry that, okay, if I'm going to meet a psychiatrist, that means they're going to put me permanently on some psychiatric medications. Instead of that, I'm just not going to go. So, so there are different protocols of treatments as well. So this is not a kind of a disorder where you will have to be permanently on treatment or things like that. So, if you're having these symptoms, or somebody who has these symptoms, are suffering with them, interfering with their work and their quality of life, please advise them to meet a psychiatrist. Okay. Moving on, cognitive behavior therapy. Like I said, this is a psychological intervention. It has been used in the treatment of depression and anxiety disorders, both in men and women. CBT aims in mainly helping people to identify and change these more disturbing negative thought patterns that could be there in depression and anxiety. So, like I said, depressive symptoms and anxiety symptoms are common psychological symptoms during PMS. So, CBT will work in these patients as well. Next is a combined oral contraceptives. Like I said, estrogen progesterone combination is given. Then gonadotropin releasing hormone agonists are also given. These are just some names which I thought maybe it will be good for you to be familiar. Then surgery. So if there are symptoms are so severe, then bilateral oophorectomy or bilateral salpingio-oophorectomy, which is actually surgical menopause, can be something which some obstetricians would suggest for a few patients. This will be only for women who have probably having very severe symptoms, and it is there for the large part of the cycle. It's interfering with their functioning to a large extent. And also they somebody who has completed their family, where I think the surgical intervention will do good for them. So this is about, the menstrual cycle, the menstrual and the premenstrual syndrome, or PMDD, that was very important for in the younger age group. As a woman grows older, we all know there is something called a perimenopausal phase or menopause. Now just let's briefly look at this. So permanent cessation of menstruation is known as menopause. This is a normal physiological process for every woman of middle age, which she goes through. In the perimenopausal phase, that is, as she is progressing towards the menopause, women may observe various symptoms, mainly, which most commonly all of us would have heard, our mothers or our grandmothers would have told us, or other people who are slightly older in our family. Hot flashes, dryness of the vagina, night sweats, disturbance in sleep, dysphoria, loss of libido. Libido is a sexual interest, and memory disturbances and other cognitive deficits. The common age at menopause in India is estimated to be around 46 years, with a mean ranging from 44.7 years to 48.9 years. So anywhere between 45 to 50 years can be menopause. The vasomotor symptoms, such as hot flashes and night sweatings, gradually progress in the menopausal transition. They last anywhere between 5 to 6 years after they start. And these are the earliest symptoms that have been reported by almost 85% of the women who are going through perimenopause or menopause. Now, more than 50% of the women in this age group suffer from sleep disturbances, and around 40% of them have reported depressive symptoms while entering into the menopausal phase. Now, this I'm quoting a lot of percentages. This is because to emphasize the importance of these symptoms and how common and how prevalent they are in the community. This again is, a pictorial representation of premenopause, perimenopause, and early to late postmenopause, and how there is fluctuation of these two important gonadal hormones, that is estrogen and progesterone. So we can see, like premenopause, there is fluctuation based on the menstrual cycle. During the perimenopause phase, there are a lot of peaks of both the hormones which keep having, there are sudden surges, sudden peaks. And menopause, again, both the hormonal surges come down, the levels come down, and there are no more fluctuations that are happening. So what are the mental health issues that a woman who's going through menopause would face? First, talking about the vasomotor symptoms. The severity and time span of the vasomotor symptoms may alter from person to person. Around 85% of women undergoing menopause phase will report vasomotor symptoms. 55% of them reported these symptoms even before the menstrual irregularities, which is a very common, or which is an indicator of perimenopause. So even before that started, these vasomotor symptoms of night sweating and hot flashes had started. The severity of symptoms gradually progresses over the years, and it reaches its summit in the late menopausal transition, and then it gradually starts disappearing over the next few years. Just like how the hormonal fluctuations that I showed in the chart would gradually subside, the symptoms also would subside. So the average time span of hot flashes in any woman is around 5 to 5.2 years. Next is sleep disturbances. More than 50% of the women report a reduction in sleep quality after reaching menopause. Now, another important point here is that with progressing age, the sleep quality also gets impaired and the duration of sleep also reduces. Around 23.6% of female in the age of width of 45 to 49 years, whereas 40% in the early 50s reported sleep disturbances. So what are the disturbances? Frequent awakenings, difficulty falling asleep, there is fragmented sleep, were some of the few common complaints which were reported. Then there are cognitive functions that are impaired. Cognition is our ability to think, memory, our ability to do our daily activities, executive functions, working memory, all these are what are cognitive functions. So something which is most commonly complained by women is something called a brain fog. That is the disturbance in mental clarity along with memory problems. And all both of these together is called a brain fog. Women undergoing menopausal transition may have trouble recalling names and to remember verbally told details. They possibly notice trouble carrying out executive functions. So, executive functions are the cognitive functions which are most important for us in our day to day functioning, also in work functioning, where we need to plan how we need to go about that particular task or how we need to go about that particular day, what task has to be done after which task for us to complete one particular activity successfully. So, they have noticed that they have trouble carrying out these kind of executive functions. Women who have had longer fertile period, which ended later naturally, were at lesser risk of developing dementia at a later stage of life. So, when we look at dementia is, very commonly what you would have known of is Alzheimer's dementia. You must have heard of Alzheimer's disease. This is a neurodegenerative disorder which is seen with progressive age, usually seen above 70, 80 years of age, and a little earlier in some people. And this is seen more in women than in men, what studies have shown. So, what the last point is trying to say is that if a woman's fertile period, that is, if there is a surgical or medical menopause which is brought in because of some other underlying gynecological issues, then there is a higher risk of them having cognitive deficits. Whereas women who have had a longer menstrual period and had a later menopause, there it is noted that their cognitive functions or their risk of developing dementia is less. Now these are all studies which have shown these results. It's not true for every individual person. This is an average. When we look at an average population, that is what this is showing. Next is mood disorders. Sadness of mood, decreased interest in activities, reduced activity, easy fatigability most of the time of the day are the most important cardinal features to make a diagnosis of depression. Okay, the prevalence of depression in females is estimated around 42.47%, ranging from 28 years to 58 years. There is around 3 times more risk for the development of clinical depression in a woman who are in their pre and the post menopausal phases. So, as it is, the second statement is talking about the very high prevalence of depression in women. But when it comes to the menopausal phase or that age, let's say 40 to 50 or 45 to 55, the risk becomes 3 times more. Various risk factors which may make a woman more susceptible to precipitate depressive episodes could be previous history of depression. When there are comorbid anxiety disorders, there is lack of good quality sleep. There are distressing and adverse life events or stresses that are going on. When the BMI is higher, that is when there is obesity. When there is smoking that is present. And when the menopause happens at a younger age. And like stresses like job loss or retirement, etc., and of course hormonal variations. Many midlife adverse events which may not act as an independent factor, but they may actually contribute for developing depression and maintaining the depression in women also could be there. Like there could be alterations in family structure and functioning of the marriage, of the woman's marriage itself. There could be daughter-in-law, son-in-law who comes into the family, living alone after maybe the children are grown up and they are moving away, having their own separate family. So the lady has to live alone now. There is retirement, or the person is returning back to the job after a long gap. So there's a change in the role that she has to take. There are new obligations as a caregivers, and so this is the age usually when the parents or the in-laws are very are older, and they might require help. So maybe the woman is taking care that taking up that caregiver role. So these are all could be the psychosocial factors which could contribute for depression around the same age. Anxiety disorders, affective anxiety, that means the cognition or the thought of being worried, that is affective anxiety, is known to trigger menopausal hot flashes. And somatic anxiety. Somatic anxiety is a physical symptom of anxiety. Like, for example, you have increased heartbeat, you start sweating, or you have tremors in your hands. Those are somatic anxiety or the physical symptoms. Affective anxiety is a cognitively, where you start worrying thoughts, when you have worrying thoughts. So it is seen that these kind of anxious thoughts itself can trigger menopausal hot flushes, and the physical symptoms of anxiety are more common cause and could be more potential target for treatment. Early perimenopausal women are more prone to experiencing psychological distress than older women. Like I was mentioning previously, at a younger age, if a woman experiences menopause, then more psychological distress could be there. Those with low anxiety levels during the premenopausal period, they might actually experience elevated anxiety during the menopausal transition. So during the perimenopausal or premenopausal phase, if there is no much anxiety noted, that can actually exacerbate at a later phase. Another very important problem that women faced in this age is sexual dysfunction. Since in general in India, it is estimated the prevalence of sexual dysfunction in females to be around 82%. So this is pretty high. And there's not much attention which is given to this, especially because women don't come up to doctors, whether it's obstetricians or to psychiatrists, with this complaint as much as men would do. The deterioration in sexual functioning is quite evident from early to the late menopausal progression. And the types of ordeals in sexual functioning which affect the woman in this transition are, there is vaginal dryness, there is painful coitus, there is painful intercourse, there is decreased sexual desire, decreased frequency, and reciprocity towards the partner sexual urges also reduces. Now, again, like I previously spoke about in PMDD, I'll just briefly talk about what are the different treatment strategies or the management strategies that are available for treating the menopause-related mental health issues as well. So, women who have mild vasomotor symptoms, they are advised for lifestyle modifications, which could be refraining from alcoholic beverages like spicy food, and then also stressful situations, keeping the room temperature on the lower side, use a fan or sweat-friendly clothes like maybe cotton clothes. Low doses of vitamin E also is advised for some women. Body weight reduction, because I said high BMI can make them more prone for these symptoms. Cognitive behavior therapy is another thing, like I mentioned previously. For moderate to severe vasomotor symptoms, most patients will require pharmacotherapy, as I mentioned, which means medications, along with behavioral and lifestyle modifications. So for this, there are two types of treatment. One is hormonal treatment, other is non-hormonal treatment. Hormonal therapy is a mainstay of treatment for women who don't have any other medical contraindications for taking hormones. So when we say hormonal therapy, it is usually a combination of estrogen, progesterone. So this is given in women who do not have any medical contraindications for taking hormonal therapy, and it can be used with safety for 3 to 5 years or till the woman turns 60 years. After that, it has to be stopped by tapering off the dose over a span of 6 to 12 months. Why this is important is as age progresses, if hormonal therapy is continued, they can cause risk of osteoporosis, which means brittle bones, leading to more easily fractures, and also it can lead to some cardiac problems also in women. Non-hormonal therapy is advised for those women who are not able to tolerate hormones, or there are contraindications, already there's an underlying cardiac issue or anything like that for hormonal therapy. Age is already more than 60 years, or they have already taken several years of hormonal therapy but continue to have these symptoms, so non-hormonal treatment might be required. For mood and non-hormonal treatment is mainly antidepressant, anti-anxiety medications that are given. Again, for mood and anxiety symptoms, antidepressants and anti-anxiety medications are given based on the severity. For cognitive deficits, several lifestyle modifications can be advised for a better quality of life, like regular exercises, green leafy vegetables, including milk, seafood, and fruits in the diet, engaging in regular social activities, participating in cognitive exercises like reading, writing, solving crossword puzzles, etc. Because maybe a working lady post discharge, post her retirement might not engage herself in cognitive activities as much as she would be doing during her working phase. But it is very good for all of us that we continue to keep our brain working and keep cognitively challenging our brain at whatever level we can, so that our cognitive functions remain sharp for a longer period of time as we age. Some medications have also been tried for cognitive deficits. Donepezil is a drug which is given for dementia, like I spoke about Alzheimer's. No, so in these patients, donepezil is given. Then there is atomoxetin and vortioxetin, which are also in the antidepressant group of medications, which are given for patients to improve their attention and concentration. So some women, these are also been tried and noted that it has helped them. But these are only given if there are very severe cognitive deficits, not for mild cognitive deficits. Then coming to sleep and sexual dysfunction. Now, for sleep and sexual dysfunction, what is very important for a clinician to do is what a clinician will usually do is try to rule out if there are secondary causes. So sexual dysfunction and sleep, like I mentioned, can be primarily happening because of the perimenopausal or the menopausal hormonal changes, but it could also be secondary to the depression or the underlying anxiety which the woman is going through. So after we address the primary cause, the sexual dysfunction and sleep might get corrected on its own. But if that is not happening, and if there is primary sexual dysfunction, sometimes there is DHEA or vaginal estradiol is one strategy which has been used, which might be helping in painful intercourse. Then testosterone is used in some patients for the treatment of sexual dysfunctions like decreased desire or frequency in the postmenopausal woman. Then various forms of psychotherapies are there, like marital therapy. Sometimes sexual dysfunction could be actually because of the interpersonal issues a couple are having. So in that cases, marital therapy or sex therapy may also be advised. Then primary insomnia, that is if it's happening without any underlying depression or anxiety, a better response is seen with cognitive behavior therapy for insomnia, non-benzodiazepine agents, medications. Then melatonin is also given. Okay, so thank you very much. So this was in brief about the menstrual cycle related and also post-menopausal related mental health issues that the women face, and how what help is available, and how they should actually be take a step forward and take help for these kind of problems. So session is open for questions.
Madam, thank you very much for a very insightful and informative and scholastic talk on mental health. On behalf of KSTA, I'm very thankful to you for this wonderful presentation on menstrual related mental health issues. Sure, if the women and also scholars who have joined will be highly benefited by your talk. There may be a few questions. Right from basics to etiology to symptoms to treatment, you gave a very good overview of the topic. So again, thank you very much.
Thank you, sir.
Umesh, any questions?
No, sir. As of now, there are no questions. I requested them to post in the chat box, or they can raise their virtual hand so that we can unmute them and they can speak directly.
Okay, one or two questions are there, madam. How
Yes,
does
sir.
society's perception and stigma surrounding menstruation affect mental well-being of a woman?
Sir, can you please repeat it?
Madam, how does society's perception and stigma surrounding menstruation affect mental well-being of a woman?
Yes, yes. So, to an extent, I think that also definitely affects a woman's mental health. Especially, I mean, in certain communities and certain areas, maybe not so much so in the educated families and in the city kind of areas, but maybe in the villages, it is still followed that women are not allowed inside the house. They're supposed to stay separately, alone, and it's almost like they're outcasted from the family during this period. So especially for women who already are vulnerable emotionally during this phase, and they are kept away from any all other social contact, that itself will impact their psychological, increase their psychological distress even more. That is something which I think definitely it has an impact.
Madam, with your experience, do women take any professional help for this PMS?
Sir, here in Nimhans, we don't see many women coming up because we see more of severe disorders here. But in regular psychiatric clinics and in private and all that, in a city like Bangalore, definitely educated women do go up to psychiatrists and they do seek help for the same, sir.
One more question, madam. How well informed are people generally about mental health aspects associated with menstruation, and what could be done to improve awareness?
First of all, sir, like the question is very, very relevant. A very poor information, of course, about mental health itself. The awareness in the society is not as much as in other medical disorders. Coming to menstrual related mental health issues, again, it is usually most of the time it is brushed off as, yeah, this is normal. Okay, this is just part of menstruation, or that, okay, because she's having menstruation, she's behaving like this. So it's more like it's made fun of. Even if a woman is coming up and trying to tell people that I'm facing this, people don't take it seriously because they don't know that there is some disorder like this, that it can be treated, it has to be treated. People don't know. How we can improve the awareness is, sir, like initiatives that you people have taken, where you are conducting such kind of webinars. So if such things are done more and more in educational institutes, because that's where we have the youth going ahead. So I think that way awareness is definitely, so from school itself, if education about mental health issues are propagated, then definitely the awareness in the coming ages will definitely improve.
Thank you very much, madam. In fact, KST organizes physical conferences and workshops as well. We would like to have one conference on women and health, most probably in March. We'll be including this as one of the topics. We'll be inviting you for a talk in our own campus, madam. KST.
Oh, thank you, sir. Thank you so much.
And we have with us Dr. Bharat Srinivas. In fact, sir has been very, very kind enough for me. He has helped me in organizing this series of webinars. He is there with us. On behalf of all of us, thank you. And I request Bharat sir for his comment. Bharat sir.
Sir, namaste, sir.
Namaste, Vanni sir.
Sir, thank you for giving me this opportunity. I have interacted with Dr. Preethi Reddy. We actually jointly prepared an educational video series on bipolar disorders where Madam was involved in a couple of episodes. These are actually available on YouTube. So she has over the years developed excellent expertise in the field of psychiatric disorders. Of course, her professional training is in the field of psychiatry. Apart from bipolar disorders, now I have seen that the way she has expressed herself is excellent, and I should congratulate both her and you, because like Madam said, this is not, the public is not aware about these things, and even if they are aware, they don't want to come forward, whether it is the technical aspects of this or the awareness or the stigma related to the mental health associated with the women's these issues. So these need to be brought out. And KSTA is the best platform, sir, for doing such programs in the future, where you can have more and more experts in the field. And so women who are professionals in this field and also lay public in general can be benefited. Congratulations, Dr. Preethi, and thank you for the opportunity, sir. Excellent, sir. Thank you.
Thank you, sir. Thank you so much.
As Dr. Bharat sir told, you explained in a very simple way that even a lay person could understand the issue very well. I'm sure in the coming days, KSTA will be organizing many such webinars and physical programs so that more people will be aware of how to overcome this syndrome. On behalf of everybody who has joined, both on Cisco WebEx and YouTube, I'm very grateful to you, madam. Thank you very much once again.
Thank you, sir. Thank you so much.
Also thankful to Dr. Bharat sir. We require your encouragement and support always. As I told
Yes.
madam, we will be organizing a program on women and health, most probably in March, and I require your guidance and help. Thank you, sir.
Thank you, sir. Namaste.
I'm also thankful to all the audience who have joined both on Cisco WebEx and YouTube. Tomorrow, one more talk related to women's mental health will be delivered by an expert. I request all of you to join by 3 o'clock. Thank you very much.
Thank you, sir. Thank you, everyone.
Thank you very much, ma'am. Thank you, sir.